My name is Cody Wright. I'm a family nurse practitioner student at West Texas A&M University, and I'm here to present my research topic for this semester. My research topic is Trisomy 21 and respiratory illnesses. Now this topic hits home for me because I have a son that just was born last year with Down syndrome. And so we'll talk a little bit about Down syndrome first. Down syndrome is a genetic disorder that causes a third copy of the 21st chromosome. This chromosome can cause different genetic defects and anatomical structure differences from typical children. Down syndrome is actually very common. It's specifically from 1 out of every 600 to 800 births in the United States are diagnosed with Down syndrome. So it is considered the most common chromosomal variants in the world. And so these children with Down syndrome typically have many issues, but one of the main issues is respiratory illnesses, and it's not well studied. So I wanted to look through some literature review and just present this to a research committee and try to show a little bit of light on Down syndrome and these respiratory illnesses. Now, as we're going to go through this literature review, I've got a few bullet points that we're going to look at, and we'll compare the different articles that I've gone through. So the first article in the literature review just brings up the point that the most common issue for hospital admissions and pediatric intensive care admissions for children with Down syndrome is respiratory illness. And so 54% of admissions into the hospital and 43% of admissions into the pediatric intensive care unit over all admissions was related to respiratory illnesses. And so this is important to remember as a primary health care provider as you're taking care of these patients and understanding what type of illnesses and issues they can have further along. Children with Down syndrome appear to be specifically at higher risk for respiratory infections due to multiple things. One is immature lung growth, which we'll talk about a little bit more in just a minute. The second part is immune dysfunction. Children with Down syndrome have T and B cell lymphopenia. Now this is a issue where they don't produce enough T and B cells, and that can cause infections, increased infections, and infections that their body might not be able to defeat without help. So that would include longer hospital stays. Another issue that children with Down syndrome have is congenital defects. Now these defects are things that happen at birth as the child is developing with the mom. And so the main defect here is cardiovascular defects. These would be atrioventricular septal defects and other heart conditions. Now 54% of children with Down syndrome have heart defects, and so these defects can cause pulmonary hypertension and unwanted stress on the vascular system that can lead to lifelong illnesses and lifelong struggles for these children. So this should be focused on especially in a good prior medical history for the advanced practice nurse. So going back to immature lung growth, children with Down syndrome have multiple lung abnormalities that are common for them. One issue is that they have a lower amount of alveoli, they have larger alveoli, and they have decreased surface area of those alveoli. So less oxygen can go through the capillary beds because of the less amount of surface area per alveoli. This can cause children with Down syndrome to have increased chances for hypoxia and longer hospital stays because they cannot control their oxygen levels as well as typical children. There's some new research out that shows cystic lung disease as an issue for children with Down syndrome, and two specific studies that I look over in literature review. The first one is a 10-month-old baby. She comes to the hospital with stridor and acute respiratory distress, and so as they performed a chest CT, that CT showed subpleural cysts around the outer border of her lungs. Now, they are unsure if these caused any issues further with the baby, but again, this is quite a new topic for this area and more research needs to be done. The specific picture on my poster shows the picture of a 7-year-old child with Down syndrome. This child has the same subpleural cysts around the outer area of the lungs. Now this child was a completely healthy child at the time this picture was taken, the CT was taken. This child did not have any symptoms, no fever, no lung issues, but they just wanted to look and see how common this was, and it just so happened that this child also had these subpleural cysts that are around the outside of the lungs. Now, these children with Down syndrome should not just be looked at in an acute care setting as these respiratory infections are acute. These infections can last over a long period of time. And that's what my last bullet point here shows. This study is a very interesting study over a span of 3 years around children at the age of 8. They tested about 300 children, half of which had recurring respiratory tract infections and the other half which didn't. They did developmental age testing to see what age these children are actually at compared to their age. Now, this left side shows the respiratory tract infections were reoccurring for those children. Their average developmental age was 3 years and 8 months. The children who did not have recurring respiratory tract infections was 4 years and 1 month. So that 5-month difference shows that there could be a correlation between recurring respiratory tract infections and children who don't have those recurring infections. So it's something that primary care providers should look into. It's very important as we take care of these patients over the long period of time of their life that they know that their provider understands that they are at higher risk for these illnesses, and that they can not only affect their lungs, but they can affect multiple areas of their life. And so we should take more precautions, and that will lead us into clinical application for these patients. And so the first and main point in clinical application involves completing a high medical history and extensive physical assessment. This should be standard of care for every patient, but specifically kids with Down syndrome need an extensive physical assessment to make sure that they don't have these issues already. And so by completing this physical assessment, we're listening to lung sounds, you're listening to heart sounds, looking at past medical history, and making sure that they're continuing to move forward the best that they can. Patients should be evaluated for any wheezing or coughing. Children with Down syndrome do not meet the criteria normally for asthma. It's very rare, and so any type of wheezing or coughing should be evaluated, assessment should be taken, and you should make sure that these patients do not have a pneumonia or any type of infection that might be causing this wheezing or coughing. Patients with Down syndrome should also be evaluated for reflux disorders. So they tend to have tracheomalacia, they tend to have weakened cartilage structures, which could cause reflux, and that reflux can lead to aspiration. Aspiration can then lead to pneumonias and other lung issues that, again, can affect these children over a lifespan. A patient's weight should be monitored, and dietary measures should be continually established, and as issues arise, it should be changed. Children with Down syndrome tend to be more overweight, and children with Down syndrome tend to be more overweight early on in their life. There's higher chances of that than typical children. So dietitians should be involved if needed, and they should be continuing to watch what they're eating and the exercise that they're completing. Pediatricians should be informed of when children take off days from school. This is important because we want to make sure that these children aren't taking many days off because they have an underlying lung issue that needs to be addressed. And finally, vaccines should be up to date. This is true for every patient, but a few of these studies recommended that children continue to get pneumococcal vaccines all the way through age 15, just to make sure that they don't get a reoccurring pneumonia that could possibly put them in the hospital for longer periods of time. So in conclusion, due to the Down syndrome having increased risk for not only infections, but longer hospital stays and increased financial strain on parents of these children, primary care providers should put their best foot forward in making sure that we are taking care of these patients that we're doing all that we can to prevent those hospital stays, prevent those extensive respiratory illnesses, and making sure that those families feel that we are helping to protect their child from future illnesses, that we are just helping them to prevent infections and continue to give them the best quality of life that they can possibly have.